So before we don't, in that way, I would like to introduce a colleague, friend, and a professor at the University of Pretoria and Numeri, and next, Professor Thomas Ebenhan, who is the head of preclinical facility at Numeri. He has been the person that has made all the preclinical molecules that has happened in that place to be a reality. He has pioneered several of the infection imaging molecules, and he is sitting in the World Molecular Imaging Infection Committee, and he's involved with the IAEA in writing what we have to do in terms of making the infection imaging a reality. Thomas, over to you. Thanks.
Thank you very much. That was a lot. Thanks for attending, and thanks for the organizers to invite me. I feel very grateful. So I'll try to give you guys, I have 20 minutes to tell you all about infection imaging on a preclinical research setting. And I'll try to tie the title of the conference a little bit in, saying back to our roots, meaning obviously during COVID, a lot of people had time to work from home and reminiscent about the past. We did the same for imaging of infection, and a very famous guy like Christopher Palesso came up with a nice paper in 2020 because infection imaging turns 50 years old. So we have this is the first sentence in the paper actually, 50 years, molecular imaging of infection, the first 50 years. Despite significant advances in the understanding of microorganisms, infection remains a major cause of morbidity and mortality. And 50 years ago, this is one of the scans, and this is a rabbit scan, scintigraphically imaged by gallium citrate, gallium-67 citrate. So that's back to the roots, indeed. During or because of COVID and during COVID, obviously there was a prolific output also on re-highlighting or highlighting the value of imaging of infection or infection, monitoring infection in general. I just have a few papers for anybody that's keen to read. There's some familiar names there as well. I invite you to go through all of them. It's very informative material. And that brings me to my context today. It's very short, but you'll see there's a lot to talk about. First, the quest for new IOI-ready pharmaceuticals. And then the second part is IOI as a research tool, because it's going beyond the actual radiopharmaceutical, what I want to tell you. So, no further ado. Again, I can't talk about everything. It's a very broad topic, and it's also, as I said before, it's not only nuclear imaging that the imaging infection makes, or preclinical setting is driven by. So it's, for instance, I won't talk about fungal probes. So there's a nice article from last 2 years ago, and there's also other modalities of IOI which are coming into use more and more. And especially optical imaging is on the forefront on using those tools to make infection imaging work in a preclinical setting. So I invite you to read those articles, which I exclude today. And what is now the advances in diagnostics of IOI? It's not taking a selfie in a BSL-3 lab, that's for sure not. But it is to drive basically what is considered the bench side into the application side. And we have very powerful screening tools for infectious diseases, etc. And we have very precise tools. And nuclear medicine is a good example where you can also make it an application. So, and ultimately we want to use the scanner. So radio-labeled infection imaging agents, we know the usual suspects eventually. So everybody came across FDG and citrate, as mentioned before, and then there's various radio-labeled lymphocytes or blood-derived, what's the word? Elements, blood elements. And then there's a few antibodies, MDP and technetium nanocolloids that are routinely used. And this is the prospects for new IOI probes. I'm using, or I have a very good friend from Baltimore that sketched this, and I'm going to keep it in the area what we explained, the uphill struggle and the valley of death for preclinical development. And I think Prof. Nergale will tell us the uphill struggle and the valley of death of the clinical after this. So you're going to be in for a treat. And without further ado, so the radiolabeled molecules for IRI can be roughly classified, and that's not exhaustive, so it's roughly small molecules and antibiotics, peptides, and then antibiotics and their fragments. I kept it to this because there's the most advances in the last years. On the small molecule side, we recently published a review paper that summarizes the essence of it, and it's for every, you see here PET radioisotopes, for most of these molecules there's also a SPECT isotope equivalent. And as you can see, the bacterial cell is outlined with various transporters, and obviously the cell wall, which is unique to a bacteria compared to a mammalian cell. So this can be used obviously for targeted infection or targeting infection specifically. And as you can see, there's cell wall synthesis targeted, there's the maltodextrin transport targeted by various molecules. You can see the nucleoside analogs, for instance, FIAO, which goes into the cell, in the bacterial cell. Then there's the folate path metabolism that is targeted, as well as sorbitol, which is a sugar that's also using a transporter to form part of the cell, and then we can use this for imaging. And last but not least, there's so-called siderophores, which are using the iron shuttle Trojan horse approach, if you will. They smuggle into the cell. On the other on the image, my left, your right, is an image from, just to give you an example, from those siderophore molecules. This is the lung pathology. These are the kidneys. And if you zoom in, let me just see. If you zoom in, it's actually really a lung pathology that they targeted. And this was Pseudomonas aeruginosa infection in the lung that they used as a target. And imaging it or delineated from the background was actually very successful in this case. Then we're coming to radioantibiotics as IOI infection or as IO agents. This is the brainchild of Arno. He's in the audience. You can talk to him. So we looked at the motivation was antibiotics are still radiolabeled. Again, SPECT and PET equivalents exist. It's a long list, but we wanted to find out which ones are really actually are suitable for imaging. Are there any, or what is actually the current state of that? And we learned that obviously they have a profound mechanism of action that we can use, which is always an advantage. Then there are successfully radiolabeled equivalents and a proper in vivo assessment, animal studies done, clinical translation for some of them, and we were interested in the relevance and limitations as well. So you can see there's a quite elaborate display of how these mechanisms of action are summarized, and there's the list of the relevant antibiotics. Again, the PET antibiotics are displayed, but there's SPECT equivalents as well. You would see that the antifolates, tiamidopine, for instance, they are suggested for infection imaging, and they're also being taken now into the clinical phase. On the fluoroquinolones, it's sort of the ciprofloxacin is an old story. I'm not going to go into detail, but it's been used in the clinics, then revoked from the clinics, and now there's a group of others, and mainly fluoroquinolones are tested for pharmacokinetic and dynamics. So is isoniazid and several others of the what I summarized as anti-tuberculosis drugs. So it is questionable, or the question remains whether these are suitable agents for imaging. But the advantages, and this will be my second half of the talk, is in studying those drugs for their biodistribution in the body, for instance. Same for the peptides, another table I selfishly highlighted where South Africa was involved. And the list is, again, selective representative for the last 5 years. There's more, if you go further back, 50 years back, if you will, then you would find more. And again, PET and SPECT equivalents are available. I chose an example. I'm not going to go into the list, but you can see there also the target investigated is normally all bacteria or fungus. And then you see an example for COVID as well, which I want to highlight. The authors did a very good job. They used what in molecular biology you would call this an empty cell, the HEC 293, and they spliced the target into the cell so they could actually do a really targeting study. And the proof of principle is proven to be sufficient, and the peptide that was radiolabeled acts as a ligand for the target. Then same for the antibodies and their fragments. We have, again, only a selected list. The list is much longer if you go further back, but those are the relevant ones that also in parts now find place in the clinics. For instance, VRC01 on the second half of the table. And again, selfishly, I highlighted our endeavors into malaria research using an antibody. Dr. Duvenhage is in the audience, you can talk to her. She started with confocal microscopy and looked at the stages of malaria-infected blood cells. And since there are several, we looked at a pan-reactive antibody that maybe matches the pathology in vivo. And micro-PET-CT was very powerful. Unfortunately, the antibody wasn't. So we have to further the quest. And Yanni has a poster. You can go and talk to her. We are following through with this. And again, I'm coming back to another example here on this list, but I'll tell you later why. Then some pointers for preclinical imaging infection projects, I should say, or imaging of infection projects, but it's generally applicable. So for anybody who is keen to work in this field with preclinical equipment, for instance, there are now guidelines. There weren't in the beginning when I started 2002, I think there was no guidelines. There was just try the scan, see what you get. Now there are really good guidelines that you can follow by the ENM or the EIR. And animal models still, that's an important part. It's still, animal models still remain limited. So the clinical need might not match what the animal can provide or what interventions we can do with the animals. And interestingly, also specifically for infection, you cannot always rely on mice. So they might be the worst. So you have to maybe go for that animal species that actually is a carrier of the disease. Then you are the closest, at least, to reality. And there could be some ethical considerations along with that. I was offered to scan bats because they carry diseases, for instance. And yeah, start simple. That's also my mantra. I said, start simple, understand the in vivo properties of your tracer. That's what preclinical imaging is for. And then tissue-based analysis is also good to prove your findings. So go further with the material that you have and try and maximize your data output. And then the standardization of readouts is tricky, but it is key to compare different agents. So that's also non-negotiable. And further down the line, okay, then IO as a research tool is a little bit of a different ballgame. We're not now talking about, in the end, there has to be a functional radiopharmaceutical. No, we're using the available radiopharmaceuticals, obviously, to drive infectious diseases research forward. Why are we doing this? Because the NIH, for instance, has a very elaborate list on pathogens that are plaguing us. I'm not going to list them, but for instance, TB is group C, category C3 pathogen. So is COVID, so is tick-borne fever, for instance, and the others are cause more morbidity even. So there's enough evidence or enough motivation to drive infectious disease research, and if we can make a difference using imaging tools, then we might as well do so. The role of preclinical infection imaging starts with maybe an obvious thing, studying the pathogenesis, so the developing of the disease. With imaging, you get unique insights into the disease pathogenesis. You may assess hideouts of the infection, and you can also study what we call the microbiome, so what is the equivalent to tumor heterogeneity. So it's not just the bacteria that sit there, it's other cells, etc. Then the antimicrobial pharmacokinetics is also important because through that you learn how to expedite your bench to bedside translation of new drugs or therapeutics, especially when it comes to new antimicrobial agents or vaccines, and you can study efficacy or predict stable cure with that. So it's a very helpful tool, and preclinical imaging, oh Lord, has. So the role further, or building on that, is monitoring and prognostication. Basically, imaging allows you to do non-invasive longitudinal assessment, which is also, it provides in the end more elegant research with less animals, but sustained statistical power. And imaging as a biomarker for drug development is quite important because you could have a very powerful radiopharmaceutical, and it allows you then to do signal intensity rather than sensitivity before and after the intervention, like a drug treatment. There's also some help from the industry side where they come up with new tools and toys to do proper imaging or workflow rather. You need specific infrastructure, safe infrastructure, because you eventually have to protect yourself from the pathogen. And with the Fantastic Four in South Africa, we could have a BSL-3, we have a BSL-3 laboratory at the moment, but the admin process for getting certified is what takes long. But once you have it, you also vetted, for instance, to combine radioactive work with BSL-3 work, which is quite unique. I'm going to skip this slide. There's a few very impressive therapy or a few applications that I wanted to run by you. It's like FDG that everybody knows, for instance, has been used in HIV-infected monkeys, and they applied CAR therapy, and actually as FDG was very sensitive. If you can see, the monkeys were 70 months off the therapy, then started therapy, and there's already reduction of lymph node involvement in the first month, which continues for 6 months prognosis, and then when they take off the therapy, then lymph node involvement appears again, as well as spleen. And they took this further, the same group took this further into using a new antibody, which I showed earlier on the list. And they want to obviously show now a CD4 pool depletion in their animals, and obviously you can quantify it. As you can see, the red columns are all reduced. And this is very promising, where I said this is where you use your tools at hand to study the disease further and understand the longitudinal aspect. Another example from my own lab is we used a standard glucose mechanism, and we wanted to understand how do we relate bacterial protein synthesis against it, and the tool allows you to quantify, and we quantified it against classic Ziehl-Neeson staining, which is indicative for tuberculosis bacteria. And the question is always, is it accurate, is it specific, or is it sensitive? In this case, it was accurate, specific, but not sensitive enough. So it's a very straightforward way to qualify your biomarker. And I'm going to skip over this in the interest of time, but it's another tool where you look at biodistribution that you otherwise wouldn't have seen. The uptake of a drug in the brain, imaging allows you to do that. And in conclusion, I want to just say infectious disease is a broad topic, as you might realize now, and then requiring time for researchers to produce relevant data in patients. And I want to close with the same guy that I opened with, saying that this was his last sentence in the paper. The next several years promise to be an exciting period. The goal of developing the ideal agents will be challenging, but not impossible. With this, I thank my colleagues and people that worked for me, people that groomed me, mentored me, and with this, I thank you for your attention.
Thank you, Thomas. That was very comprehensive, very informative, and you really kept to the time. The instruction, we won't take questions, and people will interact with you during the dinner and during tea times. The instruction reads, give men a small gift.